Good evening, everybody. We'll welcome to the Journal Club of the month of October. It's a very good article answering a very significant question. The debate about mechanical bowel preparation along with oral antibiotic has been going on for a considerable period of time. And what studies set out to show the advantage of mechanical bowel preparation ended up showing that there were more complications with mechanical bowel preparation. But however, um, further refinements have shown that whilst bowel preparation may not be required for colonic, resections and colonic malignancies, it's a different ball game as far as rectal malignancies are concerned. And hence now it is accepted that probably mechanical bowel preparation is useful in rectal cancers, that is when you are doing anti-resections, low or ultra low anti-resections. In addition, whether oral antibiotics has to be given along with the bowel preparation, that is a question this is I think challenging the clinicians. There was a concept of selective bowel decontamination, which was there for a long period of time. Same antibiotics were being used, but it again went into disrepute, but now made a good comeback. So I think we'll look at all the evidence that there is in this paper to look at whether mechanical bowel preparation with oral antibiotic is useful. So over to you, Praveen.
Yes, sir. Good evening to everyone. Today's Journal Club is based on the article Morbidity After Mechanical Bowel Preparation and Oral Antibiotics Prior to Rectal Resection. It is a mobile to randomized clinical trial conducted by Laura et al. In Department of Gastroenterology, Helsinki University Hospital in Helsinki, Finland. It was published online on March 20, 2024 in JAMA Surgery, which has impact factor of 157 and a SCR score of 6.695. Coming to introduction to the paper, colorectal surgery carries a risk of morbidity mainly caused by the surgical site infections. And within the field of colorectal surgeries, the risk of surgical site infection is higher in rectal surgery, especially if it is low colorectal or colorectal anastomosis are involved. And in addition to it, in short-term morbidity, the postoperative complications have long-term consequences that can increase with risk of cancer metastasis or local recurrence. And with high quality of evidence regarding benefits of prophylactic preoperative intravenous antibiotic exists, there is still ongoing debate whether preoperative oral antibiotics are beneficial in reducing the morbidity associated with rectal dissection. A meta-analysis showed that approximately around 50% there is reduction in surgical site infections when oral antibiotics are added to bowel preparation regimens. But the limitation of this RCTs are the meta-analysis. The outcomes were not reported separately for rectal surgery. It has the analysis of whole colorectal surgery. As rectal surgery is often preceded with neoadjuvant radiotherapy or chemoradiotherapy, and due to higher rates of anastomotic decisions, especially in low anastomosis, protective stoma is often used. And while mechanical bowel preparation is not considered necessary in colon surgery, in rectal surgery, mechanical bowel preparation reduces the surgical site infection and is widely prescribed. Furthermore, in previous randomized control trials, which focused on surgical site infections only, it is important to evaluate overall cumulative complications, and as oral antibiotics might have other adverse consequences also. Globally, the use of oral antibiotics prior to colorectal surgery is highly variable. In Germany, around about 10% of patients undergoing colorectal surgery receive oral antibiotics, while in US, it's around 2/3 of the patients. Because of these variable practices and there is lack of high quality evidence regarding the use of oral antibiotics in rectal surgery, they have designed to carry out the mechanical bowel preparation and oral antibiotics versus mechanical bowel preparation only prior to rectal surgery, that is mobile 2 trial. Here they have hypothesized that mechanical bowel
Praveen,
preparation.
One second.
Yes,
Sir, Ramakrishna sir and Shrikant sir have joined, sir.
Oh, good. Okay. Thank you. Welcome, Dr. Ramakrishna and Dr. Srikant.
Good evening, sir. Thank you.
Good evening. Continue.
So Yes, sir. So they have hypothesized that mechanical bowel preparation reduces the overall complications after elective rectal dissection with a colorectal or coloanostomosis compared with preparation alone. This mobile 2 trial was a double-blind, placebo-controlled, randomized control trial conducted at 3 large university hospitals in Finland. And there were no changes in study protocol of the trial had started, except they have added a subgroup analysis for surgical approach based on peer reviewer comments on protocol article. And this change was made before the trial was still recruiting and no data analysis had been performed. And this research plan had taken the medical ethics approval and was conducted according to the principles of Declaration of Helsinki. The inclusion criteria includes the patients who have been scheduled for elective anterior rectal resection, including low or ultra-low anterior rectal resection, along with colorectal or coloanal anastomosis due to a rectal tumor between March 18, 2020 to October 10, 2022. And tumors 15 cm or less from anal wedge on MRI or an endoscopy if MRI was not performed were considered as rectal tumors. Exclusion criteria includes all the emergency surgeries if there were bowel obstruction before the surgery, if they had a ostomy created before rectal surgery, any reason preventing the mechanical bowel preparation, or allergy to antibiotics used in the study, patients younger than 18 years, or if inadequate ability to understand the study protocol and instructions given by the investigators, and post-randomization patients were excluded if the surgery was not performed on them, or the rectal resection was not performed, or colorectal or coloanal anastomosis was not created. Randomization was done in 1:1 ratio, and it was generated by a computer using variable block sizes such as 4, 6, and 8 patients. Oral antibiotics or placebo tablets were produced and packed into sealed vials at Helsinki University Hospital pharmacies, and no person outside the pharmacy had access to this sequence. The external appearance of placebo tablets was made similar to the oral antibiotics. And after the surgeons had recruited the patients, after patients giving their informed consent, they were given the numbered vial as per the randomization stratification. And patient population was stratified according to this, according to the distance of lower edge of tumor from anal wedge. They have stratified into 4 groups. Those 4 groups are: first group are tumor less than 10 cm from anal wedge and no preoperative treatment or short course radiotherapy within the immediate surgery. Second group was tumor less than 10 cm from anal wedge and long course chemoradiotherapy or short course chemoradiotherapy with a long waiting time or with chemotherapy before operation. Third was tumor of 10 cm size or more from the anal wedge and with no preoperative treatment or no short course of radiotherapy. Fourth was tumor 10 cm of size or more from anal wedge along with long course chemoradiotherapy or short course radiotherapy along with a long waiting time. All those patients involved in the study were blinded to the allocated treatment, and after all of the data had been collected and verified, the Helsinki Pharmacy Clinical Trial Unit provided the unmasking list along with the allocated groups designated as A and B. And this is the concept diagram. During the study period, 765 patients was assessed for the eligibility, and based on the exclusion criteria, 155 patients were excluded and 610 patients were randomized into 307 patients in mechanical bowel preparation only and 303 patients in mechanical bowel preparation along with oral antibiotics. Based on the post randomization excluding criteria, 19 were excluded as in the mechanical bowel preparation group, as 3 did not undergo surgery, 10 did not have anastomosis, and 4 of them withdrew consent. So it came down to 288. In the mechanical bowel preparation along with oral antibiotics, based on the post randomization exclusion criteria, 26 were excluded, and it came down to 277. And for all the mechanical bowel preparation group patients, all patients drank 2 liters of polyethylene glycol and at least 1 liter of clear fluid. And it is bowel preparation started 2 days before the surgery at 3 p.m. and it should be completed by 3 p.m. on the day prior to the surgery. After completing bowel preparation, patients in mechanical bowel preparation along with oral antibiotic group were instructed to take 1 gram of neomycin along with 1 gram of metronidazole orally at 3 p.m. and 11 p.m. day before the surgery. And at the same time, only mechanical bowel preparation group had taken placebo tablets which were similar to the antibiotics in the appearance. This neomycin and metronidazole were chosen because of the characteristic of broad spectrum action. All patients had received preoperative prophylactic intravenous antibiotics, cefuroxime 1.5 gram and metronidazole 500 mg. Among these, 3 patients received other antibiotics as they had allergy. 2 had received ciprofloxacin and 1 received levofloxacin 30 minutes before the surgery. Diverting ostomy was used in patients with a low colorectal or coloanal anastomosis, that is less than 6 centimeters from anal verge, and was allowed in patients with a higher anastomosis in case of a non-suturable leak in intraoperative leak test, or if there were any reason for a surgeon to consider that ostomy is required, divesting ostomy is required. And after 6 to 8 weeks after the surgery, patients were called for the follow-up to undergo abdominal imaging with rectally administered contrast medium or to undergo a sigmoidoscopy to check the occurrence of surgical site infections or other complications. The primary outcomes was to assess the comprehensive complication index within 30 days after surgery. And this comprehensive complication index is a continuous measure of cumulative postoperative complication pattern, which uses a Clavin-Dindo classification. This
Hello.
Clavin-Dindo classification, sir. Hello, sir.
Suddenly your voice was not heard. I think it was a problem on my side, I think. Okay, carry on.
Yes, sir. This comprehensive complication index is based on the Clavin-Dindo classification. This Clavin-Dindo classification is the grading of the patients based on the postoperative complications. It is of 5 grades. In grade 1, there is any deviation from normal postoperative course, and it doesn't require any pharmacological treatment or any other surgical or radiological interventions. In grade 2, it requires pharmacological treatment and any blood transfusion and total parenteral nutrition if required are to be given. In grade 3, it is divided into 3A, 3B. In 3A, intervention not under general anesthesia. In 3B, intervention required under general anesthesia. In grade 4, it is of life-threatening complications and require ICU management. 4 is categorized into 4A, 4B. In 4A, single organ dysfunction. In 4B, multi-organ dysfunction. Grade 5 is as death of the patient. Based on this Clavin-Dindo classification, this comprehensive complication index has specific scores. In grade 1 of Clavin, this CCA has 8.7 score. Similarly, Clavin 2, it is of 20.09. Clavin 3 has 26.2. Similarly, Clavin 4B has 46.2. Clavin 5, that is CCA score of 100, which indicates that it is death. And secondary outcomes is measured in terms of surgical site infections, which may include superficial, deep, and organ space infections, and anastomotic dehiscence, which is graded into grade A. That is, anastomotic dehiscence doesn't change in patient management. In grade B, which requires active therapeutic intervention. In grade C, which requires repeat laparotomy or laparoscopy within 30 days of surgery. And in terms of length of hospital stay, mortality within 90 days after surgery, and number of patients who had received adjuvant treatment by number of patients needing it. And the criteria for adjuvant therapy might be due to pathological nodal positivity, lymphovascular invasion, high tumor burden, or high-grade adenocarcinoma. This anastomotic dehiscence of asymptomatic patients, they had defined as extravasation of contrast medium during CT, which was assessed by radiologist, or if there is any visible fistula cavity during flexible sigmoidoscopy, or assessed by colorectal surgeon during that 6 to 8 weeks of follow-up of surgery. And statistical analysis was done. Here, the sample size was calculated with aim of showing difference of 5 comprehensive clinical difficulty index points between two groups. With power of 90% and margin error of 5%, 574 patients were needed for the recruitment based on the Wilcox and Mann-Whitney test. Categorical variables were compared using the chi-square test or Fisher-Exact test, and continuous variables were analyzed using the mean STs and were using the t-test. Continuous variables with non-normal distribution were compared using the Mann-Whitney U-test. With Born-Ferroni correction, the statistical significance was set as p-value less than 0.01 for secondary outcomes and less than 0.05 for primary outcomes. And all these analyses were performed using the SPSS statistics version 27 IBM. Patients with missing data were excluded from the analysis of that particular variable and missing value were not imputed. Outcomes were analyzed using modified intention to treat principle, which includes all patients who were randomly allocated to and underwent elective rectal resection with an anastomosis. They also made a subgroup analysis, which includes tumor location, neoadjuvant treatment with long course of chemoradiotherapy or short course radiotherapy with chemotherapy, protective ostomy with SRO, surgical approach if it is minimally invasive or open surgery. And this subgroup analysis, the statistical significance was set as p-value less than 0.003 for subgroup analysis.
Right. Quite extensive study. Now let us, okay, we'll start with Ainas and Samir. What have you understood so far? Critique the paper. Start with Samir. Samir.
Yes, sir.
Ah,
So the paper has a good impact of purpose
yeah,
and
okay.
it's sample size. So the,
Hello.
yes, sir. Sample size is not sir.
Sample size has been calculated, correct?
And, the topic is very important.
Important, relevant.
Hmm.
Hello.
Yes, sir.
Are you in the hospital? Are
Yes,
you in
sir.
the hospital?
Yes, sir.
So go to a place where there is good internet connection. Where are you?
Yes, sir. Important. So the topic is relevant, sir.
Your
It's important for us, sir.
yeah, topic is important and relevant, correct? Okay, go to Ainas. Ainas, he has said a few points. Add anything that you know.
The study design, sir, it's a randomized control trial. So
Yeah,
that is a pro point, sir. Then
and with blinding.
blinding, yes, sir, with blinding. Then the inclusion and exclusion criteria are very well defined. They've
Correct.
also mentioned out what their primary and expected primary and secondary outcomes are.
Yeah,
Like they're defining that as well.
yeah,
Then so in addition to that, like they have like their protocol states good follow-up protocol, so like the follow-up protocol is decent, and they've also told the like they are following like the intention to treat analysis part, sir, which is
okay.
a pro point, sir.
Nikita, anything to add?
Sir, nothing in specific to add to the pro, sir. Some
Ah,
cons I felt in the protocol, sir.
yeah,
Sir, first one being they did not clearly mention about the uh, follow-up guidelines or follow-up criteria, sir. They just mentioned at 6 to 8 week once. But
hmm,
what if there was a surgical site infection in between and it was resolved?
correct.
They, like
Yeah,
number of visits they did not mention is what I was saying, sir.
correct. And Many of the patients, if they have anastomotic dehiscence which will need re-laparotomy, will not
Yes,
wait
sir.
till 6 or 8 weeks. Yeah, it can happen
Yes.
earlier than that. So I think, yeah, that is the follow protocol there was not signified, correct, not
Yes.
specified. Okay,
Yes, sir.
what else?
And sir, is modified intent to treat superior to intent to treat, sir? That was my question because other literature suggests that modified intent to treat is more biased in comparison to intent to treat analysis. Here they have used modified intent to treat.
Hmm. So what
That
do you think? Does it bias the thing? What is the modification of intention to treat in this case?
Sir, in this only the exclusions after randomization, sir. If the patient did not even
Hmm.
start the treatment, then he is not considered into the even intent to treat analysis. In a usual intent to treat, even though if patient doesn't undergo the treatment, if he is recruited into the study and randomized, we take him into the consideration.
Correct. But only thing is, if, for example, if you have not done the resection anastomosis, then you can't assess the anastomosis. If you have not done the anastomosis, how can you assess it? Or the
Yes, sir.
complications associated with anastomosis cannot be assessed. So they have rightly, they have stated in the protocol that patients who did not undergo this anastomosis or did not undergo resection, uh, have been excluded. So I think that is why they have probably used the modified intention to treat principle.
Okay, sir. And the calculation of the sample size, they took the previous
Huh.
mobile one trial into consideration, but that trial is
Correct.
about bowel preparation with oral antibiotics versus no bowel preparation at all. uh, so even they even considered like increased number of points, sir, but can we do that like
No, no. What they have
semi-related
done
study?
is they only use the data as far as the SSIs and anastomotic leak rates and things, just to have a ballpark figure as to what is the likely, because in their hospital what was the leak rate and what was the infection rate, and for you to then show a noticeable difference between the two groups, they use that as the baseline. I think that is okay. I think that is actually a positive point rather than negative, because sample
Okay.
size calculation has been done more scientifically rather than just looking at how many patients we need to do to show the difference. They've actually considered what is the existing infection rate and what needs to be done to actually show the difference is not per chance, but it is actually difference because of the antibiotic therapy. Ramakrishna sir.
Okay.
Hello. Good evening,
Hello.
sir.
Good evening,
Uh,
sir.
yeah. So, adding to that point, I think
Hello.
Sir?
Hello, Ramakrishna sir, are you there? Nikita,
hello,
are you
No.
hearing?
hello.
Can you hear me? Yeah, yes, sir.
ಕೇಳಿಸ್ತಿದ್ಯಾ ಸರ್?
ಈಗ ಕೇಳಿಸ್ತಾ ಇದೆ.
ಹಾ ಸರ್. ಅಲ್ಲಿ ಯಾವುದೋ ಹಾಸ್ಪಿಟಲ್ ಫೋನ್ ಬಂತು, ಅದಕ್ಕೆ ಪ್ರಾಬ್ಲಿ ಕಟ್ ಆಯ್ತು ಅನ್ಸುತ್ತೆ.
Okay.
Sir,
Okay.
the sample size calculation should be done based on the primary outcome. Here, the primary outcome is
Yeah.
that Clavin-Dindo classification. So that
Yeah.
complication rate they should have taken into consideration, and what is the difference, expected difference between those two groups, that should have been taken into consideration. They have taken secondary outcome, that is infection rate. That is one thing. Secondly, they have set the power at 90%, and they
Yeah.
have calculated the sample size. But after seeing the data, actually this comes later in the results. There, so many patients have been deleted, and that number they have not reached. So we will be under misguided information or misguided imagination that the power of this study is 90%. but it may not be. It will be less than that
Mm.
because whatever they have calculated, that much of patients they have not reached after exclusion of so many patients in the modified ITT.
Yeah. Anything to add, Nitya or Tanya?
Sir, nothing much, sir. Pretty much everything is covered, sir. But since I have read the paper, when they further analyze, they analyze the comorbidities also, because the other factors that can play a role in the infection and wound healing. So
Yeah.
I think they have done that as well, sir, which is quite a
But
pro.
sir, but randomization is done initially. So I think comorbidities also will be shifted because of randomization equally.
Yeah. But if you look at the groups, they are fairly well matched in terms of
Yes,
comorbidities also. Even
sir. But I think,
hypoalbuminemia.
sir, one more I feel is they are saying intention to treat, but they are saying a few variables were they are not able to collect the data. So those patients in that particular data were removed in that particular calculations. I feel
But that has been done to both groups. So I
yes, sir.
think
But the randomization will go away less because of if you basing an intention treat, randomization will be there. But if you take it as a per protocol trial, then again the randomization will go away. I feel.
I think you have a point, but I think they have not specified exactly where data was not available and where they could not, where they have
Yes, sir.
actually excluded it. So that
Yes, sir.
exclusion
And
has been
also one
done
more
with,
thing, sir. This regarding this, they are measuring with Clavin-Dindo classification, but I feel they would have mentioned about individual complication because I feel something like a pus because of antibody.
Actually, sir, this comprehensive complication index, it has 30 complications. Each complication is again calculated using Clavin-Dindo. So the 30 complications with their Clavin-Dindo scores, they have made it into 100 score. So they have
yeah.
considered all the complications possible, sir.
Yeah, I think that is actually a good thing rather than a bad thing.
No, sir. My thing is because if it is, I feel particularly these organ, if they have done something like cultures post infections, if it is because of the GIT pathology, then I feel these antibiotics so specific to that.
You mean using neomycin and metronidazole, oral antibiotics?
Yes, they are using oral antibiotics to uh, to control the GIT infections, right, sir? I mean,
No, not GH. Yeah, no. It is to what is called as selective bowel decontamination.
yes, sir.
See, the
Bowel
thing is,
yeah,
huh,
yes, sir. They are controlling the bowel flora. So if there
huh.
is, if they have made something like sepsis, I mean, this organ infections and superficial and deep, and this selective organism which is causing that. If it is something other than GIT, then it might have been a different thing else.
But generally the surgical site infection and everything is generally related to the gut organisms anyway. At least as far as I know, unless I think unless it is Staphylococcus aureus, whatever if that is the case, yeah, you have to specifically say it may not be related to the gut.
Yes,
But
sir.
those things can be taken care of by the antibiotics that you give, the systemic antibiotics that you are going to give anyway.
Yes,
So
sir.
I think so that will be taken care of by that.
And one point, sir, though it
Huh.
might not be completely relevant, the study is from, one second, sir. It ended in October 2022.
Huh.
No, sir, I was mistaken. I thought it was October 2024. I thought it was too quick for the result. Okay, sir.
24, 22. But I think it's
22,
still,
2 years.
but it does take time to compute the
Um,
data and then and publish it.
And sir,
yes.
in the results, they also mentioned about partial TME.
Huh.
Is that followed, sir, now?
I don't think, I think everybody, I think it is only probably for higher rectal tumors. I think
Okay.
they have done partial TME.
Yes, sir, but now even now for AR, they are
Yeah,
advising
I
total.
think I think you should now. I think the standard of care is TME, even for
Yes, sir.
thing. But you know what is some of the people are saying, if you take away the mesorectum, the vascularity and all those things. So that is why, if it is not required, why are you taking it out? So that is some new arguments that are coming. But I think by and large the standard of care is total mesorectal excision.
Yes, sir.
Okay, Praveen, continue.
Sir, yes, sir.
Sir, another
Ramkrishna
point
sir,
is they
sir,
should have mentioned the
Yes, sir.
experience of the surgeon, because it is the multicentric study. We can assume that everybody has got same experience, but they should have mentioned in the methodology.
They should have, but what I would say is that Ramakrishna, in their defense, what has happened is, especially the Scandinavian countries, have all gone through very rigorous process of training by Bill Heald. So Bill Heald has, video mentoring all of them. He's gone to all of these hospitals, and all of them have to be, past fit to do TME and rectal anti-resections by the respective boards. And I think majority of them would have gone through that. So on that basis, I would say these surgeons who are participating in the trial would be of kind of, they can never be of equal competence, but acceptable level of competence by all of them. So
Oh, the board should
but
approve before they do independently. Yeah?
huh?
The board should approve before they do independently.
Yeah. So what
Okay.
happens is, they all have to do at least 10 or 15 or 20 recorded TMEs, and that has to be
Supervision.
sent, and it has to be not only the procedure, the pathologist has to go through the specimen. There are no standardized pathology, this one what we call as the standard data set, and the TME should be cylindrical, not conical. Lot of number of lymph nodes, and the fat envelope should not be disrupted. A lot of pathological criteria are also there. So basically, based on those two criterias, the surgeons are, after the mentoring process is done, they are certified to carry out anti-resections. So, and majority of these are conducted only by trained and certified colorectal surgeons. So I think the process is quite robust, especially in Scandinavian countries. I know that for a fact. But I still take Ramakrishna's point, that, for example, because I worked in Europe and I had close connections with people who worked in Sweden and Norway and Finland, I know this fact. The rest of the world may not know that. So I think it is important to have mentioned the surgeon's qualification. I think that is a very valid point. Yes, continue.
sir, sir. Ramkrishna sir has said that the sample size collection should be based on the primary outcomes, sir.
Laminating. Yeah.
Yes, sir. Actually, they have calculated based on the primary outcome only, sir. Here, the primary outcome is comprehensive complication index, and based on the same CCA score of previous trial only, they have, based on that only, they have calculated samples in this trial, sir.
You repeat what you just said. Sample size was collected. This one.
Sir,
Sample size was,
based on
calculated
certain
using.
should be based on primary outcome. Here, the primary outcome of the study is the CCA, sir. CCA score only. And they have calculated the sample size based on the CCA score of the previous trial.
Okay, fine. Yeah, then in that case, that is a valid thing. Okay.
Yes, sir.
Go to your one analysis. Critique.
So, as the
No,
mentioned, sir,
is there anything
follow-up
they have missed?
criteria.
Correct.
No, sir.
Not well
Everything
defined.
they have done,
Yeah.
sir.
Okay, I think we have covered everything. Yeah, go to
Yes, sir.
this one analysis results. Yeah.
Yes, sir. Between March 18, 2020 to October 10, 2022, 845 patients in 3 participating centers are planned, and among it 765 patients were assessed for eligibility, and among them after the randomization 16 patients were randomly allocated to either to mechanical bowel preparation along with placebo or mechanical bowel preparation along with antibiotics. And this is the demographic of the patients. Here the comorbidities had been similar in the both groups, and the median age was also same in between the both groups. And the distribution between the yes, sir.
I actually went through each and every subgroup, and I think most of them are well matched.
Yes, sir. Almost all groups are being matched equally, sir. Based on the operative details, colorectal anastomosis had been done partial in 99 patients in mechanical bowel preparation and 97, which is similarly equal. And open approach was in 217 patients, and in mechanical bowel preparation along with antibiotics it was 210, which was also matchable. And in mechanical bowel preparation group, 193 patients had underwent transversostomy, 29 had ileostomy, and 66 had no stoma. In mechanical bowel preparation along with oral antibiotics, 173 had transversostomy, ileostomy of 23, and no stoma of 81. A little higher number of no stoma in oral antibiotic group.
Yeah.
And coming to primary and secondary outcomes, the primary outcome, which was comprehensive complication index, was similar in the both groups, which was statistically significant also. And surgical site infection was more in mechanical bowel preparation alone group, which had 48 compared to 23. And most of them was organ space infection, which was 43, and compared to 17 in the oral antibiotic group. And anatomic dehiscence was 39 in mechanical bowel preparation alone, and it was 16 in oral antibiotic group. And this secondary outcome of surgical site infection and anastomotic dehiscence was statistically significant. The length of hospital stay, mortality within 90 days were not significant. So, in prescribed subgroup analysis, the mechanical bowel preparation along with oral antibiotic patient had reduced overall post-operative complications. And the reduction of overall post-operative complications in this group was not demonstrated in subgroup of patients with high rectal tumors with long course of chemoradiotherapy without protective stoma. And finally, this group patients had reduced surgical site infections with low rectal tumors or with no or only short course of radiotherapy, but not in other subgroups. But this was mentioned only in the result analysis, but this was subgroup analysis was not shown in the tabular form, sir.
Correct. Yeah. Why did they not show in tabular form? Anybody?
So they actually redirected to a supplement, sir. It's extensive, the whole subgroup analysis, but they did not individually comment on what values in the main article,
Each
sir.
subgroup.
Yeah.
Though they had significant results.
I think the numbers were not sufficient, which is why they have not put it in tabular form. They have admitted that in the final conclusion or in the discussion that many of the subgroup analysis did not reach statistical significance because the numbers were small. So any
No, sir, statistically, sorry, sir. Statistically, they were significant, but they mentioned a statement saying that they are significant, but they did not put up the values in the main article, sir.
Okay, because I have not seen the supplement.
Yes, and here in the supplement, they clearly mentioned the right number of patients included, sir, like 192 only out of 288. They they came to the original values.
Hmm. So, Nikita, you only start the critique of the results.
Sir, Praveen, go back to the table. So the first and the foremost point is the missing data, sir. Previous table, first table. It's a prospective randomized control trial. So I don't think it's a prospective randomized control trial, no, sir. Missing data of this many patients, is it acceptable, or is it error is also acceptable, sir? That sounded more in this new study.
Where is the data missing? For how many patients?
Yes, sir.
Sir,
For
it was
individual criteria they have given, sir.
like 5 for this, 5 for this data, 3 for that data, 2 there, like that. They have mentioned multiple. It will be in double digits, sir. Missing data.
Yeah, but see, the thing is, you have to look at it this way. In a large study of this size, with the best will in the world, the people who actually entered the data might have made mistakes in entering certain data points. But instead of hiding it, they have been actually honest about it and said that the data is missing for these number of patients. So I think that is, that is an honest thing to do. But whether it will actually affect the final data analysis, because they have excluded these patients from the data as far as that particular data point is concerned. I think it will lead to some confusion. Srikanth?
I agree with it.
Ramakrishna sir, what do you think?
Yes, sir. It can skew the results, sir, conclusions.
Yeah.
It is possible because we don't know what has happened to these patients, whether they had problems or they did not have problems. So for each one, the number is very less, but for some of them, it is something like 9, 15. They are quite significant.
Next table, Praveen.
Yeah, carry on.
Sir, here the protective ileostomy or protective ostomy, it is significantly low in the intervention group with oral antibiotics. In contrary, even to that, our primary outcome is significant in the intervention group. Little controversial, sir, because protective ostomy is supposed to be protective. In spite of that, we are still having significant numbers in this. Is it a mistake or is it real outcome? That
No, actually,
ostomy is not productive enough.
No, I think it is more to tell you that despite the fact that patients who had antibiotics had less stoma, they still had less infection. So that means that maybe if you had comparable numbers in both, the infection rate would have been probably higher in the patients who did not receive the antibiotic.
Could be, sir.
Don't you think?
And they did. Yes, sir. Yes, sir. From the outcome, that is the idea we are getting right now, sir.
Correct. I think that is probably the point. See, the thing is, if you presume that stoma protects against, apart from anastomotic dehiscence, which can then feed to pelvic sepsis and all that, may also increase the incidence of skin and subcutaneous infections. So if the stoma numbers are less in the antibiotic group, oral antibiotic group, and still if the infection rates are lesser in that group, that means if they had similar numbers of stoma as compared to the no antibiotic group, the infection rates in the no antibiotic group would have been much higher.
Yes, sir. Sir, but there is a catch. There is a catch in this.
Yeah.
Sir,
you're completed.
yes, if the reason why they put the protective stoma is also important, sir, because they have mentioned if there is some irreparable leak, then they went for a protective ileostomy. So the irreparable leak might have landed up with the anastomotic dehiscence continuously. So that itself says that they were at high risk for the dehiscence. So the protective ileostomy was done. So if they had mentioned how many of them had leak, like a diagnosed leak intraoperatively, maybe the dehiscence values will be different, sir, like post-op dehiscence.
How can they show intraoperative leak?
They mentioned, sir, like
Test.
they did air leak test and water
Air
leak
leak
test.
test.
Air leak test. Yeah, they have done air leak test. But they have not mentioned how many of them were, the
Yes, sir.
stoma had because of the thing. Yeah, that is right.
Sir, also the
Huh.
primary outcome is the comprehensive complication index, which may include the complications which occurs at the site of ostomy. Right?
Correct.
If the patient develops
Yes,
some
yes.
complication because of the ostomies, those complications also will
Correct.
be considered to calculate the CCI.
Consider.
So in that case,
Correct.
if this number differs, that some of the CCI may be due to the ostomy. There, it can skew the
Ostomy.
conclusion again.
Sir, they did not calculate, sir.
They have not mentioned separately how
They
many
mentioned, yes.
complications CCI were because of the stoma, how many were because of the primary surgery. That
Yes, sir.
clarification they have not given.
Yes,
We
sir.
have to assume that's all. But
Yes,
some
sir.
of them could be due to that in this CCI. So without that data, it is difficult to say the actual CCI less in the one particular group which has undergone less number of ostomies. So it is difficult to conclude there.
But I think none of you have commented on a very important point. You see, the thing is,
Chemotherapy and
all,
radiotherapy, sir.
huh?
Neoadjuvant chemotherapy and radiotherapy, how many of
Yeah, but
these people have
those
been?
groups are comparable, so that is not an issue. And even whether it is low rectal, mid rectal, all of those things are fairly well, I think comparable. But what I think, we all know that surgical site infection and anastomotic leak, all these things are complications that happen, and we try to take as much care as possible to prevent it, but some of them still happen despite our best efforts. Ultimately, did it actually lead to increased hospital stay or increased mortality is a point. But if you look at
Yes.
the two groups, there is no difference in number of length of stay or in terms of mortality. So, majority of these anastomotic leaks which needed reoperation, how many of them needed reoperation? Have they mentioned it, Praveen?
Yes,
Yes,
sir.
sir.
Grade
Grade
C.
C.
Grade C, sir. 12 in
Ah.
only mechanical perforation, 8 in antibiotic groups, oral antibiotic.
But they didn't have any mortality in any of those patients.
Yes.
So I think if you look at it ultimately, I think the study has, though it has shown that there is less infection in terms of surgical site infection, it has not prevented number of mortalities that could have happened. So on that count, I don't know whether it is you can take the conclusions of the study and change your practice.
Sir, it is not clear whether this hospital stay is only concerning the primary surgery or it also includes readmissions, second surgery, that number of days that is also included. That's not very clear because the length of hospital stay is hardly 6 for this major surgery, and that part is not very clear.
No, yeah, the reason again for that is the enhanced recovery program, and which is again very well instituted in all these Scandinavian countries. So many of these people will go home the next day or the day after. So their usual length of stay would be 2 or 3 days. So I think if it comes to 6 and 6 in both these groups, that I think it is included. But I think you are right. I think there are two major lacunae in the data. One is the, as previously mentioned about the, this, the data about the follow-up, when was the surgical site infection assessed, when was the, anastomotic leak assessed, when were these patients reoperated. None of those data is available. So I think that is the major problem in terms of finally accepting this length of hospital stay and this one. Mortality, of course, is probably, obviously it's the same. So there isn't any. In fact, if you look at it, the mortality is, though it is not statistically significant, it is less in the placebo group compared to the oral antibiotic group. So, all in all,
have they given the reason for mortality?
Yes, sir.
mortality they have
Myocardial
given
infarction, aspiration
Myocardial.
pneumonia.
and
not
sepsis.
related to surgery.
No,
sir.
sepsis is there.
Sepsis.
Sepsis is there as one of the causes for death.
One the thing I didn't understand. The organ space infection and anastomotic lesions are very much higher in placebo group.
Huh.
But why? How come that the length of hospital stay is same in both the groups?
That is the thing. So what they have failed to mention is how was the follow-up done and when were these patients reoperated, and then what was the sort of length of stay of these people and everything. So in the longer this one, with the the group analysis, yes, I think that it comes up to same. The length of stay is 6 and 6 in both groups. But maybe they could have specially mentioned the number of people who had the complications and how long did they stay in the hospital and what was the when was the reoperation done, and these details might have been useful. Maybe in the additional one, is there all these data available, Nikita?
No, sir.
No, sir. They
About
have not
length
given.
of stay is not mentioned.
Okay.
Whenever
No.
we calculate the length of hospital stay, we should define the discharge criteria. And also
Correct,
should
yeah.
mention whether the readmissions were
Reoperation,
considered into this data or
reoperation,
not.
yes. Correct. All these things should be
That
mentioned.
part is not
Correct.
very clear here. So,
Yeah.
say lacuna.
So go to the discussion, Praveen.
What is the critic? What are given?
So they have analyzed various factors, but against this, in the protocol, they said that they have modified for subgroup analysis to do, but they did not mention the subgroup analysis in the result path, sir.
Okay. Now let me ask Nikita, I'll ask Nikita first. Tell me about Bonferroni correction. Nikita?
Sir, it's usually done for the error, sir.
To avoid what error?
To avoid false positives, sir.
So what is that error called?
Type 1.
Type 1.
Type 1 or the alpha error. Yeah. So you have to this is done to, so what is the sort of setting in which you use Bonferroni correction?
Sir, I didn't understand the question, sir.
See, when will you use Bonferroni correction? Will you apply Bonferroni correction to everybody, every study that you do?
No, sir. Like if you have multiple factors,
Multiple comparisons of the same data set. If you are comparing the same data set, but you are doing multiple analysis, then you use the Bonferroni correction. So how is it correct? How is it actually calculated? Do you know?
no, sir, not exactly.
See, basically what you have to do is to, to counteract the multiple comparisons. What happens is then if it can actually inaccurately reject the null hypothesis. See, the thing is, all studies, especially the randomized control trials, you have a null hypothesis, and your job is to prove the null hypothesis wrong. That is the that is the, for you to show the difference between two groups, you have to show that the null hypothesis is, wrong. So if you incorrectly prove the null hypothesis is wrong because of multiple analysis, so Bonferroni correction will try and correct that defect. So basically, what you have to do is it is called the alpha, which is the alpha is the desired alpha level, it is the alpha error, and the m is the number of hypotheses that you are testing. So if you do that, then by testing each individual hypothesis, you will be able to reduce the alpha error. So that is the Bonferroni correction. We can also do the p-value adjustment based on the number of tests, but that will also give you the same result. But generally, the calculation is done using alpha divided by m, where alpha is the desired alpha level and m is the number of hypotheses. So that is why if you see the p-values in these studies are different compared to the usual p-values. P-values are 0.05. Here they have made it as 0.01, I think 0.02, and for the subgroup they have made it 0.03215 or something like that. So that is because of the Bonferroni correction. Did you follow or not follow? All of you?
Yes, sir.
Follow.
Yes,
Yes,
sir.
sir.
Okay. Right. Now go to the discussion.
Coming to discussion, in this double-blind placebo-controlled randomized clinical trial, it showed that mechanical bowel preparation along with oral antibiotics had overall fewer postoperative complications and less CCA score. The overall incidence of surgical site infections, especially the anastomotic dehiscence, were low in oral antibiotic group, and no major adverse events was associated with oral antibiotics, except there was one Clostridium difficile infection was noted. And this Mobile 2 is the first high quality prospective trial comparing oral antibiotic along with bowel preparation with bowel preparation alone. However, two small, underpowered, unblinded randomized control trials with methodological concerns that included only patients undergoing rectal dissection have been published. The one study was published 16 years after their recruitment, and the other study they used inappropriate intravenous and oral antibiotics. And both the studies showed that there was a reduction in surgical site infections who received oral antibiotics. In addition, there are other few large trials comparing oral antibiotic along with preparation and bowel preparation alone, but these trials did not report the outcomes of rectal or left-sided anastomosis separately. One trial which showed a large number of rectal anastomosis, and it had showed that there was reduced surgical site infection, but there was no subgroup analysis with patients undergoing only rectal dissection. There was other small trials which showing different types and locations of colorectal anastomosis, but in all these trials they included rectal dissections along with left-sided colectomies and sigmoid dissections, which have different complication risks. According to this study, it showed that
Don't go to conclusion yet. Don't go to conclusion. Nikita, what is your overall feeling about this study?
Sir, it's a relevant and intentional study, but the results I'm not completely convinced with, sir. And
Completely
comparing it
what?
with Mobile 1 trial, it's very controversial results from both of them, though it is for colon surgeries and it's rectal surgeries.
Okay. Tanya, what is your overall impression of the study? Tanya, are there? Hello? Is Sania there or not?
Hello, sir. Sir, can you hear?
Yeah. What is your overall impression? I can't hear you. Can anyone hear her? Hello?
No.
No, sir.
Nitya. Okay, Nitya, what is your impression?
Sir, it's a elaborate study, but like Nikita said, there is some controversy comparing to the Bowel 1 and 2 trials. But although the surgeries were completely different, that other one is for colonic surgeries and rectal surgeries, but overall, good study, sir. Like it is a randomized control study, so I would say they have done extensive studies, sir.
Okay. Srikanth, what is your overall impression?
Good study and then with the good numbers. But the follow up and then what was the protocol for follow up and then all those things were missing. That's all.
Yeah. Ramakrishna sir.
Yes, it's a good study, and I think if you in your hospital, if you get a sufficient number of cases, if you are doing, one of the PGs can take up this study for next dissertation or your paper presentation.
Yeah.
Because if further studies, if they support the same thing, then that will reinforce and that becomes the standard of care.
Yeah. So my overall impression is that this is the first study of its kind comparing oral antibiotics with the mechanical bowel preparation without antibiotics. So first randomized placebo controlled blinded study. So and the numbers are quite impressive. So I think majority they have actually taken care to try and reduce the alpha and beta errors and also confounding factors. They have the groups are evenly matched. The subgroup analysis they have not given in this study, but subgroup analysis also show significant differences in certain subgroups which they have mentioned. And I think the only major flaw that I can find is that the how the patients were followed up in immediate post-operative period. When was the surgical site infection detected? How was it detected? And though they have used the Centers for Disease Control (CDC) it's one the criteria for wound infection, so SSIs, they have not actually detailed the follow-up protocol of the patient and patients who were reoperated, the grade C patients after grade C, correct, Praveen?
Yes, sir. Yes, sir. Great, sir.
Praveen, is that
Yes, sir.
grade C?
Grade C,
Grade
sir.
C
Yes.
patients who were who were reoperated. All these things if the details were given, it would have been better. However, I think and they have been honest about the certain data points being missing in the thing, which may happen in almost all studies of this magnitude. Overall, I think other point which Dr. Ramakrishna said about the number of stomas being higher in the placebo group and stoma related complications, if they had actually mentioned that separately, maybe that would have added to the more validity of the study. Overall, I think they have shown that the surgical site infections and anastomotic leak rates are reduced in the and oral antibiotic group. I think it is a good study, and more studies of this nature will, I think, only add to the value. They have actually discussed all the previous studies and the criticisms of those studies, and probably they have addressed some of the criticisms and some of them, because I think this is research is a constant learning process. So I think maybe if we write to the authors, they may give you the information about the follow-up protocol and all those things. But in a study of this nature published in a very reputed journal like JAMA Surgery, I think it was their duty to actually share the details of the follow-up. but which they have not done. Okay, conclusion, Praveen.
Yes, sir. This result of this randomized clinical trial, they show that mechanical bowel preparation along with oral antibiotic resulted in fewer oral postoperative complications and fewer surgical site infections and anatomic lesions compared to mechanical bowel preparation alone. And based on these settings, mechanical bowel preparation along with oral antibiotics should be considered as standard treatment in patients undergoing elective rectal resection. Further follow-up of the patients included in this trial will give a light on long-term, especially oncological outcomes after mechanical bowel preparation with antibiotic versus mechanical bowel preparation alone.
Think it is definitely clinical relevant. Would you change your practice?
Yes, sir.
I think you should, because there is already proof that selective bowel decontamination, separately has shown that it is, useful in reducing the surgical site and anastomotic.
Change your practice means you will do what?
You give
You add oral antibiotics?
You give
Yes,
oral
sir.
antibiotics along with bowel preparation, especially only in rectal cancers. For colonic cancers, you don't need to. For
Yes.
rectal cancers, see why? Can anyone answer this question? I think Nikita or Praveen or Sanya or Swan. Why is the rectal cancer different to colon cancers, and why do you need bowel preparation in rectal cancer? Hello, anyone? Why don't you need mechanical bowel preparation in colonic cancers, but as opposed to rectal cancers?
For a long period, the stools will be in the area because of storage.
Huh?
Stools will be stored for a long period in the rectum compared to colon and these things.
No.
High pressure.
No high pressure. See, the main thing is, see, you are going to retain the left colon in rectal cancers, and that is anastomosed, to either the lower rectum or renal canal. Okay.
Yes, sir.
So even if you actually do a transverse colostomy or a loop ileostomy, which is more common, the fecal column is still there in the left colon, which could drive the sepsis either in form of surgical site infection or if anastomotic leak does happen. The anastomotic leak complications and the effect of anastomotic leaks can be more devastating if there is a fecal column that is there in the colon that you have used to anastomose. So even if you have given a stoma, that fecal column will persist and that will drive the sepsis and infection. So you have to give bowel preparation for rectal cancers, which may not be the case for other colonic malignancies. You followed?
Yes, sir. Yes, sir.
Yes, sir.
Okay, right. So on that basis, I think we should consider changing our practice.
Sir, if they have did a subgroup basing on T1, T2, T3, T4, can it be much more beneficial, sir? Can we, basing on that, we can give to T3 or T4 specifically?
Yeah. That is because many of these people would have had pre-operative neoadjuvant chemotherapy,
Yes,
chemoradiation,
yes,
and
sir.
all this. So obviously, those people are probably more prone to developing infection. So on that basis, you definitely should give them. Yeah.
Sir, I didn't follow that column of colonic fecal matter, sir. Even if in colon surgery, sir.
See, in colonic surgeries, for example, if you are talking about right hemicolectomy, there is no such thing, or even extended right hemicolectomy or left hemicolectomy. But in the patients who have had anterior resection, what happens is you mobilize the splenic flexure and bring it down and anastomose. So the fecal column which is there is still there. So if you give bowel, because many of these rectal tumors, they would be occupying 2/3 or a half of the circumference. So you can never uh, even with enema or whatever, you will not be able to clear the entire fecal column. So which is why you have to give them bowel preparation. You understood now?
Yes, sir. Yes, sir.
Okay. There will be an element of subacute obstruction in patients with rectal cancers, lower, almost all rectal cancers, because they would be occupying about, early ones may not be, but the bigger ones, they will be occupying a third of, or half or more than half of the circumference. So you cannot clear them with other forms of bowel preparation. You have to be a proper mechanical bowel preparation. Okay, I think Praveen, well done. I think you have covered all the things. I think you should have put up a slide on the Bonferroni correction and some of the statistical methods that are used. I think
The
even
short
if
notes in the group for that correction.
put it up, and also see, the thing is, the relevance of the student T test or chi-square test or the Man-Whitney test. I think all of these things, because they are the ones which are commonly done, it is important to put, just go through each of these things every time you come across this. Then only you will understand when all these things are used. Okay, good night.
Good day.
Thank you, Dr. Ramakrishnan, Dr. Srikanth, for your
So thank you.
very
Thank
good
you, sir.
inputs. Thank you.
Thank
Good
you.
night.
Thank you, sir. It was a nice discussion.
Good night.
Good night, sir.